Good afternoon. I am going to work my way through this introduction today. You'll have to excuse me because I have a little bit of just stuff going on with my throat, so my voice is a little weird, but I'm really excited that you were able to join us today for this webinar, and we are recording it, so hopefully we will have it up for you soon after the webinar today. This webinar is on exercise and congenital heart disease treatment. And we're sure you're going to find this information very interesting and useful. It's a topic a lot of us don't hear about, and I think this information will help you. The webinar is going to be 1 hour long. At the end of about 45 minutes, we're going to open it up for questions. And if you look on your screen, in the GoToWebinar screen, there's a hand-raising feature. It looks like a little yellow hand. And you can use that. Once we get to question and answer time, you can click that and it will show you have a question, and I'll call your name and unmute you and you can ask the question. If you don't feel like you want to ask it out loud, you can type your question into the question box and I'll read it for you, and that's fine too. If you're listening on your computer, please make sure that your speakers are turned up so you can hear. You can also listen in on the telephone number that was part of your registration email. There's also a technical support number on that email as well. If you're having any sort of trouble with GoToWebinar, you can call that number and hopefully they'll be able to help you.
Yeah, you can.
Once the recording is complete, we'll put it up on the Mended Little Hearts website and we'll let you know that it's up there. And I'm really excited to introduce our speaker this afternoon, Dr. Nicholas Madsen. Nicholas Madsen joined the Heart Institute at Cincinnati Children's Medical Center in July of 2012. He attended the University of California at Davis, where he graduated with honors. He earned his medical degree with honors at the University of Washington in 2005. Dr. Madsen completed his residency in general pediatrics and his fellowship in pediatric cardiology at Seattle Children's Hospital in Seattle, Washington. In addition, Dr. Madsen earned a master's in public health from the University of Washington in 2011. Dr. Madsen's clinical focus is in general inpatient and preventative cardiology. Specifically, Dr. Madsen aims to understand the implications of traditional cardiovascular risk factors such as obesity, hypertension, dyslipidemia, and sedentary lifestyle on persons with congenital heart disease. Additionally, he is focused on the long-term outcomes of persons with congenital heart disease as it relates to physical activity. Dr. Madsen has received several national awards for his research and is an active member of the American Heart Association and American Academy of Pediatrics. And I'm going to turn it over now to Dr. Madsen.
Jody, thank you very much for the introduction. So hello to everyone out there. Today, as Jody mentioned, we'll be talking about exercise and congenital heart disease, and we'll be talking about the good and the bad and the ugly as it relates to exercise in the congenital heart disease population. I appreciate very much the introduction from Jody. I'll also mention that for those of you that are interested, you'll see my little Twitter name down at the bottom of all these slides, and I tend to discuss issues as it relates to congenital heart disease, in particular physical activity and diet, especially in the congenital heart disease population quite a bit. And so if you find any of this interesting, please feel free to check out that as well. So getting started, I said I would start with the good. And the good is, as you see on this graph, and you'll notice what the graph shows is along the bottom, you see 4 decades, the 1970s, 1980s, 1990s, and 2000s. And then along the y-axis, on the left-hand side of your screen, you see the mortality percentage. And then as you go over and you look on the other side, on the right side, you see that we're looking at 4 different congenital heart defect lesions: VSDs, tetralogy of Fallot, transposition of the great arteries, and hypoplastic left heart syndrome. And what you can see on this graph is nothing but good news, really. If you look at the VSDs, the mortality is going down by decade. But as you get into the more complicated congenital heart disease types, you see that we've made incredible strides in terms of mortality, which leaves us now with what the good news is that patient survival is now expected. Well, what do we do now that patient survival is expected, and what are the consequences of that? Well, that gets us into some of what may potentially be the bad. If you look at 3 different decades again, now you're looking at the 1990s, 2000s, and 2010, the world in which the children born with congenital heart disease are surviving in, or more specifically the country here in the United States that these children are surviving in, is changing very drastically all around them. And as you can see over the 20 years from 1990 to 2010, one of the ways in which their environment has changed is in terms of obesity. So if you look at the states in light blue in 1990, you can see how many of them have transitioned to the orange or darker red in terms of what percentage of the population is now obese. Well, what about obesity in the congenital heart disease population? So this is a graph taken out of a study from Pediatrics, and this is a study performed at 2 centers, Children's Hospital of Philadelphia and Boston Children's Hospital, where they looked at obesity and its prevalence in the population. So if you look along the left-hand side, you can see the percent prevalence of obesity and overweight in different populations. And if we look first here, I'll put some red boxes up, the control population. So these are non-congenital heart disease children. And you can see that about 17 to 18% of that population is obese, with another larger percentage making up the total of overweight. Now, if we compare that to the column right next to it, you can see that HD no int means heart disease no intervention. And you can see that a little bit less overweight in that category, but basically it's almost entirely the same. Well, what about the children with congenital heart disease that have had operations? So if you look at the first category, it says 2V. So those are children with 2 functioning ventricles that have had some sort of intervention like tetralogy of Fallot or transposition of the great arteries. Well, you can see that their amount of obesity, while a little bit less, is still significant. So the rate of obesity in this population is about 13%, and about the same amount of overweight in addition to that. The Fontan population doesn't quite have the same amount of obesity and overweight. So we can say, well, what conclusions can we draw from this? The conclusions that this paper came to, is obesity is a common, significant additional risk factor for long-term cardiovascular disability in children with congenital and acquired heart disease. Which is to say that even though the rate of obesity and overweight is slightly less in some of the congenital heart disease population, it is still of a significant number of children who have these additional risk factors for long-term cardiovascular disease. And why is that important? Well, that's important because these children have their heart disease already. It's not just that they're part of the general population. So specifically what they said in the paper is, given the known benefits of normal weight and exercise participation, advising against inactivity, obesity, and other unhealthy lifestyle choices, and communicating these concerns to the referring physician should be an important part of the pediatric cardiologist's care of children with cardiac disease. Well, I said I would talk about the good, the bad, and the ugly. So what is the ugly part? Well, in joking fashion, we can say, well, the ugly part is, the question is, do I have to exercise? And many people have weighed in on, do I have to exercise? Henry Ford apparently thought that exercise is bunk, and if you are healthy, you don't need it, and if you are sick, you shouldn't take it. And this concept of if you are sick, meaning if you have a chronic medical condition, you should not be engaging in exercise, is something we'll be talking about quite a bit. A famous educator from our past, Robert Hutchins, said, whenever I feel like exercise, I lie down until the feeling passes. Well, I would argue that maybe we shouldn't take those kinds of attitudes towards exercise, and we should be celebrating exercise in the population. And certainly we celebrate exercise quite a bit in our culture, as we can see here with the United States scoring a goal at this year's World Cup, and many of us jumping up and down in our living rooms. Well, going beyond some of the difficulties with exercise, with regards to engaging in exercise, what are some of the things that get in the way of exercise in our population? And I think that's really the ugly in this equation. What are the risk factors in our culture? Well, we know that kids 6 to 11 spend an average of 28 hours a week in front of the TV. And unfortunately, that's not 28 hours doing exercise in front of the TV. And we know that 71% of kids 8 to 18 have a TV in their own bedroom, which is only promoting the screen time. In addition, we know that 75% of kids have access to mobile devices at home. So it used to be you just had to find the TVs in the house and then you turn the TV off and then they're not getting the screen time. Well, clearly we all know that that's not the way it works anymore and that people are sitting in front of their devices. And the key is that they're sitting down. The average kid daily use of mobile devices has tripled over just the last 2 years. And what's really important is that the age group using mobile devices is getting younger and younger and younger. Well, what are the risk factors of being sedentary? Well, in the general population, there is a mountain of evidence that suggests that sedentary behavior is very unhealthy. We know that it increases the risk of metabolic syndrome. We know it increases the risk of cardiovascular disease. It increases the risk for obesity, increases the risk for high blood sugar, hyperglycemia, and type 2 diabetes. We know it's related to premature mortality, and it increases the likelihood of participating in risky behaviors in adolescence. So we know that in the general population, being sedentary is a significant health risk factor. Well, you might be asking yourself that you tell me that obesity will become a terrible problem for my CHT child in the future, but is physical activity safe now? Is it safe to be physically active? Is it safe to go out and exercise and play soccer? Is it safe to jog on the weekends? Is it safe to be climbing around on the playground at recess or after school? Well, this is actually not a new question, and I like to bring up this next study because I think it's very illustrative. So this is from Seattle, Washington, from a pediatrician named Abe Bergman and a cardiologist named Stanley Stamm, and this is actually from the 1970s. And they were looking at the morbidity of cardiac non-disease in school children. Specifically, what they wanted to know is how are kids behaving when they don't have cardiac disease, but there's even the sort of concern for cardiac disease. Specifically, what they looked at are 18 children, as you can see in the top left, who had heart disease present, and they looked at 75 children who had no heart disease, but were once told they had a murmur, but that murmur was ruled out and that they were told they were normal with regards to their heart health. Well, what they found is in the heart disease population, 8 of them were restricted from activity, potentially correctly or incorrectly, but 8 of the total. What they found, which I think is really important, is that in the group of patients or a group of children who had no heart disease, but at one point had worried that they had heart disease, 30 of them were restricted from activity. And I worry that that restriction from activity, which is present even in populations that don't have heart disease, is really pervasive in our population of children who do have heart disease, who were born with congenital heart disease. And what is the effect of activity restriction owing to heart disease on obesity? This is a study from just a few years ago, and I'll kind of skip to the conclusions and highlight them for you. And what they demonstrated is that activity restriction was the strongest predictor of risk of overweight and obesity at follow-up. So they followed children and wanted to know whether, if they were activity restricted, did that have any impact on their body habitus? Did that have any impact on their health? And clearly it did. That those who were activity restricted were at greater risk for overweight and obesity. They were at greater risk for sedentary lifestyle. And that goes back to the slide I showed you earlier, that if they're engaging in a lot of sedentary lifestyle, they're at tremendous risk for acquired cardiovascular disease. Another study to kind of goes along the same vein, and this is a study out of Belgium from 2006, looking at adults with congenital heart disease. More than a third of these adults did not play sports or engage in exercise of any type. And this was a group of adults who should not be activity restricted in any way. They showed that the congenital heart disease population had a higher prevalence of obesity again and high blood pressure compared to non-congenital heart disease individuals in Belgium. And what they noticed is that when they went through the records of these children, these adults with congenital heart disease, they noticed that pediatric cardiologists do not properly discuss healthy lifestyles with their patients and families. They were not discussing exercise. They were not discussing activity. They were not discussing diet. And when asked why, they said, well, that's the job of the pediatricians. Now, I don't know how many of you have had the experience of going to your pediatrician to talk about something to do with your child's congenital heart disease, but I would guess that the majority of you would not find a pediatrician who is very willing to make recommendations about activity and exercise in regards to your child with congenital heart disease, because they would assume that's the job of the pediatric cardiologist. So clearly, I think, we're missing the mark. What should we do? Our kids have congenital heart disease, and thankfully, through all the advances of the last few decades, they're surviving. But they're surviving in a culture of sedentary activity, they're surviving in a culture of obesity, and they're surviving in a culture where they are restricting their activities because the cardiologists are not telling them or encouraging them to be physically active. So we could ask our kids to just go out and play and run in the grass and dance with their friends and be physically active. But you may ask yourself, well, it can't be that easy, because clearly my child has a cardiac history, and that must be important in some way. Well, the 36th Bethesda conference concentrated on physical activity in the congenital heart disease population. So a group of experts got together and said, well, let's discuss this concept of being physically active and being born with congenital heart disease. What should we do? Well, the first thing they did is they separated those CHD survivors into two categories. They said, well, let's talk about the category where physical activity is clearly dangerous. If you've had heart surgery in the last 3 months, you should probably not be out training for a marathon. And that makes sense. Then they said, well, what is the heart function of that child or adult with CHD? And if it's severely depressed, if they have severely depressed heart function, then probably physical activity does not necessarily do them any good. And what is their history of tachycardia, specifically arrhythmias or abnormal tachycardia? And they looked at atrial tachycardia and ventricular tachycardia, and they started to separate the population of people with congenital heart disease into categories of a tachycardia that should not impact their recommendations about activity and others that should. And with all of those considerations, they came up with sport-specific recommendations for those people with congenital heart disease who had normal or near normal ventricular function, who did not have worrisome tachycardia, and who did not have surgery in the last 3 months. And they came up with these guidelines that are highlighted here. And this can be a little bit confusing, and I'm happy to go back to this at the end. But what they did is they decided to break sports into two separate categories. Along the bottom, they broke sports into sports that increase the dynamic component of the activity. And dynamic component means things that are increasing your endurance. So as you move from the bottom left to the bottom right, you are asking the body to do something that requires more dynamic movement and requires more endurance. Along the left-hand side, they also broke sports into categories of static, increasing static components. And static components is like increasing the amount of weight that you're lifting. So as you go from low, it's not a power activity. And as you go higher to the top left, you're going into a category of high power. And so if you look along the bottom, A here is a low dynamic activity, and 1 is a low static activity. So these activities are things like billiards, bowling, cricket, curling, golf, and riflery. Well, I don't know how many of your kids are doing a lot of billiards, bowling, or cricket, or curling, but that's not really addressing the question for most of our population. So what about increasing the power of the activity? Well, that gets to things like weightlifting. When your child wants to know, hey, I would like to get involved in weightlifting, what kind of recommendations can we discuss? And so that category is a category 3, but still category A, so a category 3A. Or what about those kids who are really into running or soccer or tennis? So that's not a power activity, but it's an activity that requires a lot of endurance, so that's a category 1C. And then what about those sports that actually involve both, such as triathlons or rowing or cycling? There's both a lot of power and a lot of endurance required. So they broke sports into these 9 categories to begin to make some recommendations. As an example, I have these 4 listed congenital heart disease conditions. There are many others we can discuss. There are recommendations for all congenital heart disease lesions, but I think these are some illustrative ones. So for example, for tetralogy of Fallot, they said that exercise is actually recommended for all people with tetralogy of Fallot unless they meet those initial 4 considerations. They have had surgery in the last 3 months, their heart function is not normal, or they have worrisome ventricular arrhythmias like ventricular tachycardia. How about looking the row below, transposition of the great arteries? If they've had an atrial switch, which is the procedure that we used to do for transposition 20 plus years ago, then they're limited to category 1 and 2A categories. But an arterial switch, so the procedure they would have had in the last 25 years, they are actually yes to all. There are no limitations to their exercise unless they meet one of those first 4 criteria that we discussed. Fontans, on the other hand, are limited to class 1A only. And then Epstein's, if it's mild, yes to all. Moderate, class 1A only. If it's severe, no to all. However, what I want to discuss with these recommendations is that this is based on consensus opinion. There is not actual evidence to drive some of these recommendations. So the authors of this document, including Jeff Tobin here from Cincinnati or Jane Newberger from Boston, admit very freely that they chose very conservative recommendations. Certainly in the Fontan population, being limited to category 1A like golf and billiards is very limiting, and in some ways we worry that maybe it's too limiting for that population. Another very important consideration is that these recommendations were for exercise, and exercise is not the same thing as physical activity. Those guidelines we just reviewed show that they apply to adolescents who participate in an organized team or individual sport that requires regular competition against others as a central component and places a high premium on excellence and achievement and requires systematic training. So what does that really mean? That means that those recommendations are for sports where your coach is yelling at you to try harder, to get your hands off your knees and get back to running, to beat the opponent to the ball so that your team can win. That is not the same thing as being physically active. Being physically active is pulling your bike out of your garage and riding around the neighborhood. Being physically active is taking the dog for a very long walk or a hike with your family. Being physically active is jogging 3 miles on the weekends to stay active. These are not the same thing, and one does not exclude the other. Now this next, if you thought that first graph was confusing, this next one is even more confusing. This is from the European Society of Cardiology from 2012, and so that's the Bethesda guidelines were from 2005. And what they did is they broke their recommendations into what are the ventricles like, what is the pulmonary artery pressure like, what is the aorta like, is there a history of rhythm disturbances, and is there a history of abnormal saturations during rest and exercise. And what they said is that the ventricles are behaving normally, there's no dysfunction, if the pulmonary artery pressure is low, if the aorta is not dilated or only mildly so, if there's no history of arrhythmias, if there's no history of being cyanotic, then you're category A. And what does category A mean? That means that you can keep going right down here and that you can participate in all sports and all elements of physical activity. And there's some very sort of specific criteria here about what that means, but essentially it means you have no restrictions at all. Now then, as you get into the middle of this, there's a blend, and you start to think about, okay, are you category B, C, or D? And that can either shift you over here to the left, where you can participate in all activities, or you're shifted over here to the right, where you have severe systolic dysfunction. You have moderate or severely elevated pulmonary artery pressure. you have significant arrhythmic burden or malignant arrhythmias. Well, that clearly is a very different person, and as a different person, you should only be engaged in very limited activities. So what I'm saying with this is there are benefits to physical activity. There are benefits to physical activity in the general population, but what I would like to discuss here today is that there are probably even greater benefits of physical activity in the congenital heart disease population. So let's talk a little bit about the specific benefits of physical activity as it pertains to all persons, not just the congenital heart disease population, but the general population. We know that physical activity improves your vascular function, the function of your blood vessels. We know that it improves your coronary perfusion. Your coronaries supply blood to the heart itself and makes your heart healthier, and physical activity improves that blood flow. We know that physical activity improves heart failure symptoms, meaning it minimizes the heart failure symptoms. And we know over and over again that being physically active improves your quality of life scores. Well, that's the general population. But doesn't that apply uniquely to the congenital heart disease population? Who has abnormal vascular function? Those children born with coarctation. Who has abnormal or potentially abnormal coronary perfusion? Those people born with transposition. Who has heart failure symptoms? Children with single ventricle physiology. And who has to worry about quality of life? Well, that's all of us, clearly. So let's delve a little bit into the science of this, and I'm happy to discuss it more, but I don't want to get bogged down into this. But when we're looking at vascular function, the function of your blood vessels, as you get older, we know that your endothelium, as part of your blood vessels, and its ability to dilate in response to certain needs, it goes down over time. So you have normal endothelial function. As you age, you begin to develop endothelial dysfunction, and at the end, it becomes very abnormal. However, what we know is that if you're physically active, this curve shifts to the right, meaning instead of being 50 and showing abnormal endothelial dysfunction, at 50, this curve is shifted over so that you still have normal function. Well, if you're born with potentially abnormal endothelial function, such as coarctation or other conditions, bicuspid aortic valves and other conditions, and then you're not exercising, you're not taking advantage of the opportunity to normalize your vascular function over a longer period of time. This is a detailed slide, but basically what this slide is showing you is that during exercise, there's increasing shear stress, which sounds bad but is actually good, on the inside of your blood vessels. This represents the blood vessel wall, and this is the stress of blood going past your blood vessel wall, and that's increased during exercise. And what happens with that? Lots and lots of good things. Your inflammation goes down. Your cholesterol goes down. Your antioxidants go up. And then, as you can see, there are many other positive effects of physical activity, and just being physically active and increasing the shear stress of your blood on the blood vessel walls is good for your blood vessels. And if you're born with potentially blood vessels that aren't quite normal and you're not exercising, we're missing the opportunity to have these positive effects. I talked about coronary perfusion. So this is a picture of not a congenital heart disease picture. This is a picture of coronaries. So this is coming off of the aorta, and as the coronaries brings blood, which is now highlighted in contrast, down to the heart. Well, you can see up here, this is the thickness of this blood vessel, and then as it gets down here, it's significantly more narrow because of plaque. This is the plaque that is a result of sedentary behavior. That's the result of obesity. That's the result of an unhealthy lifestyle. Well, what are the benefits of physical activity? Well, as I just talked to you about, it improves vessel wall endothelial function. But it also allows for there to be regression of atherosclerosis. Atherosclerosis is that plaque inside the blood vessels. And with physical activity, that plaque can melt away. With physical activity, you form new vessels, so that if certain vessels are blocked, then you have the promotion of new vessel growth. And as I mentioned earlier, there's less inflammation, so anti-inflammatory benefits against chronic diseases such as congenital heart disease. I talked about heart failure symptoms. So looking at something called myostatin, which is a negative regulator of skeletal muscle growth, meaning it discourages skeletal muscle growth. It's also expressed in the heart muscle as well. And when you have heart failure, myostatin is up. And so that is negatively impacting muscle growth and development. Well, what happens with physical activity? We know that it's inhibited by physical activity. So myostatin, which is elevated in heart failure, especially in congenital heart disease kids or adults, if you are physically active, you turn down the amount of myostatin in your heart, and so you don't have that negative impact on your muscle growth and muscle development. And then lastly, we talked about quality of life. So there was an aortic valve defect study out of Sweden that showed that physical activity, just 3 hours per week, is associated with the best possible health-related quality of life. Another European study looked at adult congenital heart disease survivors in a 12-week exercise program. And again, I stress, this is physical activity. This is not exercise at the sort of high school football program. This is a walking program for 54 adults. And by the end of the study, the participants rated that they felt better, they could do more, they were burning more calories, and very importantly, they were happier with their level of health. So we started with congenital heart disease survivors are being discouraged potentially from being physically active. We know we have guidelines about exercise, but we don't have good guidelines about physical activity. What to do about this information? Well, the American Heart Association identified this concern, and 2 years ago the American Heart Association came out with a scientific statement talking specifically about promoting physical activity for children and adults with congenital heart disease. And this was put out by many of the experts within this field. This is a longer paragraph, but I think it's important, and I'll highlight some of the important features because I think this, to me, really sums up the whole discussion. The American Heart Association recognizes the importance of physically active lifestyles to the health and well-being of children and adults with congenital heart defects. Research on physical activity among patients with congenital heart defects is lacking. There is no evidence regarding whether or not there is a need to restrict recreational physical activity among patients with congenital heart defects, apart from those with rhythm disorders. Again, I talked to you earlier about the Bethesda guidelines, and there were restrictions in that, less so than many people adopt, but there were restrictions. But remember, if there's one thing that you can take from today's talk, exercise and physical activity are not the same thing. And all the research on exercise and restricting exercise is not the same thing as research on restricting physical activity. And I think that's spelled out very nicely in this paragraph. And so what did they conclude? Therefore, counseling to encourage daily participation in appropriate physical activity should be a core component of every patient encounter. And what patient encounter is that? Is it the encounter with your pediatrician? I think that can be a part of it, but really the encounter is with your cardiologist. So what can you do with all this information? Well, I would encourage you, the person with congenital heart disease, or you, the parent of a child with congenital heart disease, to talk to your cardiologist every visit about what you could be doing to be more physically active. Realize that your child, or you yourself with congenital heart disease, have major risk factors for acquired cardiovascular disease. There's the heart condition itself, and then there's the environment we live in, where we are too sedentary, there's a higher prevalence of obesity and overweight, and that there is a lack of physical activity. Again, very importantly, realize that scientific evidence against activity is lacking. Know that activity is possible and that it can be done very safely. Promote physical activity. Do what you can to promote physical activity in your child. Do what you can to be physically active if you yourself have congenital heart disease. What else can you do? Well, at Camp Joyful Hearts, where here in Cincinnati we have a camp every summer that's a week long, where the children come and stay with us, and we do everything we can to promote physical activity, whether it's dance, whether it's games of kickball, whether it's zip lining up and down our ropes courses, whether it's simple physical activity like diving on a slip and slide, or really stylish zip lining as well. So I think, you know, the take-home messages for this are really that physical activity is not the same as exercise, and that physical activity is enormously important in the congenital heart disease population. We know it's important for everybody, but it's probably even more important in the congenital heart disease population. And I'll put in one other plug here. In a few weeks, we have our 3rd annual Heart Institute Family Education Day here in Cincinnati, where we discuss a lot of these long-term outcomes in the congenital heart disease population. And this year, our theme is talking about caring for a new generation of survivors. Jody, was kind enough to join us last year and gave a wonderful presentation. We're delighted again this year to have some more wonderful speakers. So with that, I would be happy to open it up to questions, and we'll take it from there. Thank you very much.
That sounds great. Thank you so much. Every time I listen, I mean, you know, I've heard this a couple times in different places, and you change it according to your audience, and I'm aware of that. But I learned something additional every single time I listen to it. It's just fascinating, and it's so important for our audience. And so I'm going to ask the participants, if you want to type in a question, I'm going to read a comment more than a question by Jeremy too, but either use the little hand raising feature or go ahead and type in your question for Dr. Madsen and I'll read it out loud. Both of them work just fine, so either one. But Jeremy says, I feel like this study has followed my life and CHD journey, as I was mildly obese when I was officially diagnosed at age 12, and then I was restricted initially. However, I decided to make a life change on my own. In my junior year of high school, I decided to start getting in shape, to the slight dismay of my cardiologist. Now I am a fit adult post 2 open heart surgeries, and my cardiologists have changed their key in regards to restriction and now use me as an example to other patients. And I can attest to that because, Jeremy says he's given a few speeches on popping the bubble to CHD parents, as my parents placed me in a bubble. Do you have that conversation with your patients and parents? And I can attest to Jeremy's being in shape because I follow him on Facebook, and he is such a nice-looking young man and in great shape, and I'm just so pleased to have him as part of our community. So I just didn't know if you had an answer to that question.
Well, I think that I wish I had sort of a Jeremy here in Cincinnati to help me sort of move this message forward, because Jeremy so perfectly highlights the whole talk. I mean, I think that comment in a few valuable sentences really highlights the message that I'm trying to move our field forward. When we restrict patients because of some old non-scientifically proven worries about the effects of physical activity on their health, I mean, it's as if we're giving them a medicine that is going to reduce their health. I mean, unless they meet very specific criteria wherein we know exercise can be harmful or physical activity can be dangerous, then we should be doing everything we can to promote physical activity for all the reasons that Jeremy highlights. He is now fitter and healthier, but I get the sense, you know, through what is being said and unsaid in those comments, that he is much happier and would rate his quality of life much differently. And I just really commend Jeremy for what he did. And it's interesting because I guess I'll comment on this as well. What Jeremy is saying ever so politely is that he didn't listen to his cardiologist, and he did what he thought was right. And while certainly I would promote listening to your cardiologist, you know, sometimes we're not right. And I think what is most important is having a two-way dialogue. And it sounds like that Jeremy was able to sustain that with his cardiologist. And you know, I think cardiologists and pediatricians are in fear of making the wrong recommendation, and so restricting seems like the safer choice. But I would argue the vast majority of the time it's actually the unhealthy choice. It's the unsafe choice. And anyway, bravo to Jeremy for being such a great inspiration to all of us, including the cardiology world, the cardiologists themselves, I mean.
Yeah. And so Jesse asked, my son is 7 and we have taken the road of letting him self-limit. Is there an age where parents need to set limitations? Good question.
Yeah, that's a great question.
And she has a single ventricle child too.
Yeah, it's a great question, and one I hear a lot, and I think sometimes what is a follow-up question to that is, well, if I allow them to self-limit, and then they are getting really good at sports, are they in line for a great disappointment because they'll have to be limited later? You know, I find that kids, at least the kids I see and the kids I talk to and the families, the kids are very aware of their physical abilities. And I think they're very aware of where their skills are and what they can and cannot do. I think self-limiting is the key, unless there's something very specific that suggests that you should be restricted because, you know, you have severely depressed ventricular dysfunction. Then self-limiting is exactly what we should be doing. We should be listening to our bodies. And now we have to be honest. So if a child is self-limiting and they're 13 and they start to have some weird racing heart symptoms whenever they're exercising, well, we need to make sure that the conversation is open enough that that can be discussed, and then that can be evaluated by exercise testing or something of the sort. But I think that self-limiting is where we start with most kids in the sort of elementary school age, and I think, to me, that's where we should continue to go because they know their bodies the best, and as long as they're reporting symptoms that they may be having, I don't see us as a congenital heart disease community getting in a bad spot where now we've allowed people to self-limit and then they're out doing more than they should be doing and in harm's way. You know, I think that these children have lived with their condition every day of their lives, obviously, and know themselves extremely well. And so rather than place artificial restrictions on them that aren't really specific to who they are as a person, I think we should continue to listen to them and to continue to promote physical activity as something they like to do and something that's good for their health.
Well, Laura asked another question that I think you probably commonly hear, and thank you for answering that last question. Laura has a baby with HLHS, and she knows of I'm assuming an adult with CHD who has practiced every sport and extreme activity that she could imagine, and she said this woman is an inspiration and encouragement. So she's wondering, given that her baby has the same thing, how does she know when to set limits, or should she push her, you know, when her child gets older, push her to physical activity, and how does she know when enough is enough? And I think this is a really good question. I think it also speaks to, you know, one child with hypoplastic left heart syndrome is not another child with hypoplastic left heart syndrome, and so there's certainly very vast differences from one kid to the next.
Yeah, I absolutely agree. You know, while one child with the Fontan circulation may have a single ventricle that's a left ventricle and really vigorous and working, you know, normally, that's different than a child who has a moderate or severely depressed function of their right ventricle. But the child that has the depressed ventricle, they feel much differently than the child who has the normal ventricular function and no history of arrhythmias. And so again, they'll let you know how they feel. They will, you know, the reason that I put that slide in there where I say exercise does not need physical activity, as long as the child can self-govern their activity, they can rest when they need to rest, or they can slow down when they need to slow down if they're out on a run, then they're not going to overtax their body. If they're in a situation where they're 15 and they're playing in a basketball game, and there's lots of adrenaline and lots of competitiveness, and the coach is saying, run harder, run harder, run harder, run harder. Well, that's a different situation, and you can potentially get into trouble in that situation if not properly counseled. But I think in the situation of a child who is given the opportunity to be physically active according to their own desires, wants, capacity, they're going to push themselves appropriately. You know, I think of the kids I see at camp who are not, who are under the watchful eye of the cardiologists, which is me at camp, and some of our cardiology nurse practitioners and nursing staff, but they're not under the eye of their parents, who maybe have limited their activities in some way, and the kids will come up to me and say that they did more today than they've done in a long time, and they feel really good about themselves. And we talk to them and say, well, don't do more than you can. You should not be doing this and getting completely blue in the face and out of breath and feeling like you're going to pass out. Then you've pushed yourself too far. But if you've given yourself a little bit of a challenge and done a little bit more, these kids often come away from camp feeling like, wow, I can do a little bit more, and as long as I'm listening to my body. But I will stress what Jody said at the very outset. One child with a Fontan physiology is not the same as another child with a Fontan physiology, and that's why, of course, I say, in addition to listening to your body, you should talk to your cardiologist and ask their recommendations. But if your cardiologist says that no child with a Fontan should ever be physically active, then I would encourage you to discuss some of the evidence that I presented today, because I think that is that's an attitude that, at least in my mind, is a few decades behind the times.
I agree. I also think, I was watching all of your statistics on screen time and everything, and I'll tell you what, getting kids out in front of that screen when they're even on the screen in school, they go to school, they're on the computers and everything. It's just, it can be very difficult to push a kid to get out and take a walk or play outside these days. And the areas outside are not always safe as they used to be. You can't just send a kid out into the neighborhood and not worry.
Yeah, absolutely. So I think we have to be even more sort of directive, and we have to be even more sort of conscious that these are the risk factors that are pushing our child in the opposite direction of good health, and we need to start these habits early. And as so many of the congenital heart disease families have been through, the first year or 2 years or several years have been really hard because you're in and out of the hospital, you're multiple operations. But as soon as the child is well enough, they're 3 months from their last heart surgery and they're feeling recovered, do what you can to be out and be active with your child. Again, being active doesn't mean finishing first in a marathon. Being active means taking a hike or a walk with the dog or a bike ride or a jog or playing basketball or foursquare in the backyard, or just being active and doing everything we can to promote physical activity, because we know being physically active is good for everybody's health, and my argument is that it's even more important for the health of a child born with congenital heart disease.
Absolutely. Dana asked, would you put any limits on a child with a heart transplant? Her son is 3 and 2.5 years post transplant.
Yeah, so I think that there are some recommendations with regards to transplantation, and a lot of it goes back to what's the function of the transplanted heart, meaning the ventricular function, and then also some of the sort of history of rejection. But the vast majority of people can be very physically active. So, I think Eric Compton, I don't know how many of you know his name. Eric Compton is a professional golfer who's had 2 heart transplants. And while golf is not the same as running an Ironman, he walks 18 holes and often more multiple times a day. So those of us who wear little step counters on our wrist, he's walking 15,000 steps a day and remaining physically active after having had 2 heart transplants. And he comments a lot, if you read some of his backstory, on how important it was for him to stay physically active. He had his first transplant, I believe, at age 12, maybe something around there. And he was active as a child, and it was really important to him and his family to remain physically active. And again, while one transplanted patient is not exactly equal to another transplanted individual, the truth is that there's usually something that can be done to promote physical activity. And you know, if you're worried about the function of one's heart, then as I talked about with the Myostatin example, being active is actually just as good for you as some of the medications that we ask you to take.
Absolutely. I am going to unmute Jessica Petrie, and Jessica, I'm unmuting you, and then we have another written question from Ganesh. Jessica, you're unmuted.
Hi, Jessica.
Jessica? She unraised her hand. Okay. So I'll read the question from Ganesh. And this is one that a lot of people have also, a very good question. They all are. You've explained physical activity as it relates to the vascular capability of the heart. What are your thoughts on contact sports like karate or soccer? And I would add in baseball to that, getting hit with a baseball. Have you seen any issues for kids who have had open heart surgery adversely effective as a result of their chest cavity opened up for surgery? And this, his daughter has DORV, ASD, VSD, and COARC.
Yeah. So, so I think that as long as you are more than 3 months out from surgery, that the sternum is very well healed, and it's, you know, just like any other bone. If you break your arm and have a serious fracture of your arm, then it's in a cast and it takes weeks to months to heal. But once it's healed, that bone is as good as it was prior. And so the contact sports like basketball or soccer or baseball, you know, getting hit in the chest with a baseball, I do not recommend any of the sort of extra chest plate protectors or any of those. I haven't found any evidence that that actually does any good, and that I actually haven't found any evidence that the sternum of a child who's had heart surgery, after it's well healed, isn't as strong as it was prior to heart surgery. So I think that for me, you know, the one caveat to that would be, of course, there are some children who are on Coumadin or other blood thinners because of their heart condition, and there the contact sports recommendations change a little bit. But for somebody who's not on a blood thinner, who's had a heart surgery, but it's well healed, there should be no limitations with regards to their ability to engage in contact activities.
Yeah, I know that's a big concern, and you see a lot on some of the heart boards, so like stuff about heart guards and everything. So, and I think we have time for one or two more questions, but Jeremy asks, and this is an interesting question too, do you see the cardiology community partnering with health life coaches and or trainers to help address this issue? This is a plan of grandeur that I've had for years and had conversations with my cardiologist, but just not sure how to move it forward.
Yeah. Jody, repeat. It was partnering with
like the health life coaches. Like I think, like you know, trainers would be like personal trainers and stuff.
Yeah. Well, I think there's plenty of room for that, and you know, one of the small areas where people are starting to do that is cardiac rehab programs. So, you know, cardiac rehab is a rehab program that started originally as a rehab specific for adults who've suffered a heart attack, and then it's a cardiac rehab program that then helps them get back on their feet and back to their pre-heart attack state of health as best they can. And we here in Cincinnati, and certainly other centers around the country, have begun to have cardiac rehab programs for our patients so that they can get back to being active. And you know, and part of what's being done is to say, well, we really want to promote being physically active, and so we really want to promote these cardiac rehab programs. But I think that that's just a small drop. And Jeremy, you know, you're welcome to contact me anytime, because I'm very interested in what we can do to promote being more active in our community, and how someone like you can be a great inspiration to lots of our families and individuals with congenital heart disease, because we have certainly not done enough, and I would argue we've actually we've gotten in our own way. You know, these restrictions that have been around a long time have really affected people negatively. I mean, I've had talks before where I've discussed physical activity and congenital heart disease, and adults with congenital heart disease come up to me afterwards with tears in their eyes because they couldn't play basketball growing up, and they had a tetralogy of Fallot, and somebody restricted them with that. And they hear this talk, and they think, all I wanted as a kid was to play basketball. And, you know, it's not intentional, but there's some harm done in that. And so I think anything we can do to begin to sort of melt the ice of this activity restriction would be very positive.
And then we have one more question is from Jesse. This is another question that is really, you know, hard to figure out for parents, I think, is what is the best response you've seen or heard to give a CHD child, elementary school age, to respond if someone asks them why they can't run as fast, for example. And I would say, like, at all ages, and along with that, do you, when kids get older at Mended Little Hearts, you know, we really promote the kid talking directly with the cardiologist, and you know, very as early as possible, and asking his or her own questions. And so what kind of advice could you give a kid like that? Like recently Joshua asked if he could wrestle, and so, you know, but what does he say when other kids say, why can't you do this?
Yeah. Well, I think it's, you know, you can take multiple approaches. I mean, you can say, I was born with a heart condition, and even though my heart condition allows me to be healthy day to day, I have some limitations on my activity. But I think, you know, the other part of that is to really sort of help our kids embrace the fact that we're all born differently. We're all born with certain talents and with certain challenges. And if we were all born as gifted athletes, then we would all be in the Summer Olympics. But the fact is that we're not all in the Summer Olympics because we're all a little bit different. And so we should all be approaching activity within you know, the confines of who we are. And so, you know, if somebody comes up and asks your child, well, why can't you run as fast? The truth is they can say, well, I was born with a heart condition, but I run as fast as I can. And I think that that's the part where I really want the kids to be encouraged to run as fast as they can, that they're allowed to sort of govern their own activities and to try as hard as they can. And then to, of course, all the while encourage all their other gifts, you know, whether it's singing or writing or math or telling jokes or whatever it may be. You know, we all have different gifts and we all have different challenges, and in reminding them that while one child in their class may be faster than them, they don't have the same skills in math, or they don't have the same skills in reading or singing or arts or any of those other fields.
I'm going to just check and see. Oh, we have one more really quickly. I got like 1 minute. And yes, Laura, we will have a copy of the presentation. We'll have it recorded, and we'll post that on the website. And then, well, yes, and Ganesh, we do have a whole, he asked if there any relationship between heart surgery and ADHD and ADD. And if you look at the neurodevelopmental issues in CHD Kids webinar that's on the Mended Little Hearts website, that is answered very well by Dr. Brad Marino. And so very good question, but there's a whole webinar on that issue. So thank you all for attending today, and thank you so much again, Dr. Madsen. It's just been wonderful and enlightening, and we really appreciate having you here today.
It's my great pleasure. It's really wonderful to be able to discuss this topic, and I really appreciate sort of the questions from the audience. It's as you know, as everyone can see, this is something where we still have a lot of work to do, and I appreciate everyone's interest.
Thank you. Everyone have a wonderful evening. Bye.